Hello, I'm Arvind Bhimraj with the Houston Methodist DeBakey Heart and Vascular Center. I'd like to invite you to the 4th Annual Heart Failure Management Conference for patients and caregivers, which is being hosted at Houston Methodist. This conference is a complimentary virtual conference this year and is designed to help patients and their caregivers receive information and support on how to manage and live with heart failure. We will focus on aspects that are not typically covered during a visit with your healthcare provider. We are excited to have various members of Houston Methodist discussing on stress management, medication management, staying fit, and eating healthy when you have a diagnosis of heart failure. We're also featuring Chef Peter Cox from the West End with a cooking demonstration. Please visit our website for more details, and I hope to see you there.
Hello, I'm Dr. Alpesh Shah from Houston Methodist DeBakey Heart and Vascular Center.
And I'm Dr. William Zogby, Chief of Cardiology here at Houston Methodist. Although the pandemic prevents us from gathering in person, we recognize how important it is for all of us to continue our medical education. Thus, on behalf of DeBakey Education, we're pleased to invite you to the Cardiology for Non-Cardiologists Conference on Saturday, May 22nd, 2021, which we're hosting virtually, so that you can learn from anywhere in the world. At this one-day conference, you'll learn to identify common risk factors, guidelines, and treatment approaches for cardiovascular diseases. You'll also learn about the latest medical and surgical therapies for heart disease and advances in managing common clinical cardiovascular condition. Additionally, faculty will discuss the clinical challenges often associated with caring for patients with heart disease.
We offer continuing medical education and nursing credits to those who complete the course, so it's a great educational opportunity for physicians, physician assistants, nurse practitioners, nurses, and other healthcare professionals in cardiology and cardiovascular specialties, internal medicine, family practice, critical care, and emergency medicine. We also encourage residents and fellows in training to attend.
We hope that you join us for this conference and look forward to seeing you virtually in May. As we stay apart to keep our communities safe, I encourage you to explore more of DeBakey CV Education's online resources to learn and earn credit from anywhere in the world. You can subscribe to our DeBakey Education channel on YouTube to stay current. We wish you well and hope to see you next year in person in Houston.
Good afternoon, and welcome to the Methodist DeBakey Heart and Vascular Center Multi-Modality Imaging Conference. My name is Karla Kurrelmeyer, and I'm here with Dr. Faisal Nabi, and we're going to give you a whirlwind tour of the multimodality imaging of cardiac masses and cardiac source of emboli. What I want to go through is basically just let you know that if you have any questions for us, you can join by text by texting DeBakey to 37607 and just text in your message, or you can join by web by going to pollev.com, enter DeBakey, and respond to the activity. So we will go ahead with that brief introduction and get started. So I'm going to talk about the echocardiography assessment of cardiac masses and cardiac source of embolus. When you look at echocardiography and compare it to CT or MRI, there are advantages. The advantages are it's dynamic, it's a real-time evaluation, the extent of the mass within the heart can be determined. The hemodynamic consequences of the mass on the chambers and on the valves can also be assessed. And also predisposing conditions that may have led to that mass can also be identified, such as an apical aneurysm or rheumatic valvular heart disease. There are disadvantages, though, of echo when compared to CT. And some of those disadvantages include suboptimal image quality. About 10 to 15% of patients resulting in either more invasive measures such as TEE or missing the mass altogether. A narrow field of view, so the extracardiac manifestations of the mass are not delineated. You only see the mass within the heart, and you can't see, for example, if it's a malignant tumor coming from the lungs, you can't see where it originated from. There's a possibility of mistaking an ultrasound artifact for a mass. And an echo cannot provide data on the tissue characteristics of the mass, so it can't tell you whether the mass is predominantly fat or calcium or fibrous or thrombus like CT or MRI can. The most important thing to know when trying to identify a mass using echocardiography is trying to determine if it's a normal variant, if it's an artifact, or if it really truly is an abnormal cardiac mass. And the best way to do that is to start with just knowing the normal structures and variants that may simulate a cardiac mass on echocardiography. In the left atrium, you have the raphe or the Coumadin ridge or the Q-tip, sometimes called between the left upper pulmonary vein and left atrial appendage. It can be especially prominent in some patients and give the illusion of a mass. The atrial suture line after cardiac transplant also can be prominent and look like a mass. And you can have artifacts secondary to calcified or prosthetic aortic valve, artifacts secondary to mitral annular calcification, or a mechanical mitral prosthesis, for example. In the right atrium, the crista terminalis, which is that tissue right before the superior vena cava, can be especially prominent and look like a mass. A Chiari network or a eustachian valve can be prominent and look like a mass. You can have lipomatous hypertrophy of the interatrial septum and the right atrial free wall, which can look like masses. And then you can have artifacts from pacemaker wires and catheters that can mimic masses, or the atrial suture line after cardiac transplant. And the LV, you have accessory papillary muscles, LV tendons, accessory aberrant chordae, you have accessory mitral valve tissue. All of this can look like masses when it's just additional normal structures. And the right ventricle, you can have an especially prominent moderator band, which happens frequently in pulmonary hypertension. The papillary muscles also can be enlarged in pulmonary hypertension and look like masses. And you have pacemaker wires and catheters that can give you the illusion of masses. So how can you tell if it's a normal variant, if it's an artifact, or an abnormal cardiac mass? Well, there are four things that you can use. The first is you can look and see if the mass is located in the heart on multiple different views. So if you look at it in the peristernal views and it's along the septal wall, well, when you look at it in the apical and subcostal views, it should also still be along the septal wall for it to be a true mass and not just an artifact. If it's located in the left atrial appendage, left atrium, or mitral valve or aorta, you really need TEE, because TEE is superior for looking at these posterior structures and getting rid of artifacts. If the image quality is suboptimal, especially delineation of the endocardium, you really do need to use echo contrast, because that will get rid of any sort of artifacts and tell you whether or not that mass is really present. And finally, you need to integrate that echo with the clinical data. So this is an example of a patient, and you can see that the mass here is located in that posterior mitral valve annulus. You can see it on the peristernal long in the left-hand panel, the peristernal short. You can also see it in the apical 4 in the third panel, and finally the fourth panel is just with color. When you look at it, it looks very calcified. It's very well circumscribed. It's pretty much isolated to that posterior lateral mitral annulus. This is just classic for caseous calcification of the posterior lateral mitral annulus. And again, this is just one of those findings that occurs with aging and degeneration. So here you see we've got TEE images on the bottom. On the upper panels, you've got transthoracic images. You can see that there's a very linear structure along the septal wall on those transthoracic images, and you also can see it in the apical images, and you can, on the TEE images down below, let's see if we can get them to play again for you. You can basically see that there's an abnormal structure, linear structure that goes across the whole ventricle, and on the short axis you can see that there's what look like accessory papillary muscles, and that's exactly what this is. Accessory papillary muscles, some are apically displaced, some are basally displaced, and you can see that there's accessory chordae tissue connecting those accessory papillary muscles. So in this one, you can see that there's a very mobile mass in the right atrium on this apical 4-chamber view, which is zoomed up on the right. It's very mobile. It's very classic for an appearance of a eustachian valve, and you can also see that the interatrial septum is aneurysmal because it's bowing back and forth depending on the pressures within the left atrium and right atrium with the cardiac cycle. And finally, in this one, you can see that the mass is along the interatrial septum. There's sparing of the fossa ovalis. You can also see there's a little tiny mobile mass in the right atrium. When you look at the other TEE view at 136, you can see that this infiltration that you see in this septum that's sparing the fossa ovalis has gone all the way around the right atrial free wall. So this is classic for somebody with lipomatous hypertrophy of the interatrial septum and RA free wall, and that's just a catheter that you're seeing then in the right atrium. So once you've decided that it's not an artifact and it's not a normal variant and it actually is a true cardiac mass, how do you then go about using echocardiography to determine whether or not it's a thrombus, a tumor, or a vegetation? Well, there's 4 different things that we use in the echo lab to try and help us determine what it is. One of those is the location. So a thrombus is usually in the left atrial appendage if it's somebody at atrial fib or somebody with mitral stenosis. It'll be in the LV apex if it's somebody with regional wall motion abnormalities such as an apical aneurysm, or it'll be in transit in the IVC on the RA or the right ventricle. If it's a tumor, it can occur on all cardiac structures, including the pericardium, the myocardium, the LA, the RA, the valves. If it's a vegetation, it predominantly just occurs on the valves. Now the appearance, a thrombus is usually pedunculated or spherical if it's in transit, and it's more layered if it's in the left atrial appendage, or a mural thrombus in an LV apical aneurysm. A tumor, the appearance is going to vary, and a vegetation is always very irregular, highly mobile on the low flow side of valves. Associated findings are very helpful because, again, with that thrombus, you're looking for concomitant reasons for that thrombus to be there in the first place, such as LV dysfunction with wall motion abnormalities like that apical aneurysm that we talked about. You're looking for mitral stenosis to cause a low flow state in that left atrium, or atrial fibrillation. Or you're looking for RV dysfunction that tells you that there was a thrombus in transit that already hit the lungs. For a tumor, you're looking for invasion and obstruction of the chambers or valves where it's located, and also collapse of those chambers. And for a vegetation, you're looking for valvular abnormalities. You're looking for either regurgitation or obstruction from the mass. The clinical history is also very, very important in guiding you to try and determine, is this a thrombus, a tumor, or a vegetation? And on the next few slides, you'll see the clinical history will be listed there, and it is very helpful in most of these cases. So this is a 48-year-old man with syncope. And the question here is this a tumor, a thrombus, or an abscess? You can see that there's a very large pedunculated mass, looks very homogeneous. It's filling up most of the left atrium there in the long axis and the apical views, and basically it looks, the only thing that's abnormal here is in those in that peristernal long axis view. It looks like the stalk is attached to that posterior wall and also on that apical 3 rather than the interatrial septum. But other than that, it is classic for a myxoma, which is the most primary cardiac tumor in adults. So this is a 68-year-old woman who came in with shortness of breath. And again, you can see there's a very pedunculated mass located there in the IVC. And these are echocardiograms that were taken on 2 different days. So on the very first day, or this was actually, you could see that they picked up this pedunculated mass in the IVC. And on the subsequent day, this mass had already progressed into the right atrium. And now it's trying to get across the tricuspid valve into the right ventricle. So this is absolutely a thrombus in transit. So this is a 21-year-old woman who presented with dyspnea, fever, and chills, and all of this happened after using IV drugs. And pretty much what you're seeing here is a very mobile mass up there in the right atrium on that peristernal long axis view. When we zoomed it on the upper right-hand panel, you can see it's a very irregular, very highly mobile mass. When you look at the short axis on the lower left-hand panel, you can see it's much longer and flag-shaped than we realized, reaching all the way to the pulmonic valve. And when you look at that 3-chamber view, that gives you a clue of exactly what the etiology of this mass was, because you can see there's a little hole right there in the membranous septum, ventricular membranous septum, and the mass is around that hole on the low flow side. So this is a classic example of somebody with endocarditis due to a membranous ventricular septal defect, and in this case, it was Staph aureus. She also had multiple pulmonary emboli from the Staph aureus, and likely cause was the IV drug abuse. So this is a 19-year-old woman with lupus and altered mental status. Let's see if we can get these to play. There we go. And basically what you can see is she's got, on these echoes, there's diffuse thickening of that tricuspid valve, but it really looks like it's coapting just fine. And but it's diffuse thickening from the leaflet tips all the way down to the base. It's not especially mobile, it's just diffusely thickened. And this is a classic of somebody with a valvulitis or Lehmann-Sachs endocarditis, and her altered mental status was subsequently determined to be due to lupus cerebritis and not a cardiac source of embolus. And this is a very rare thing that you're going to see. So basically, this is a 74-year-old guy who basically had hemodynamic compromise after an elective PCI and lateral STEMI. And what you can see is there's this huge mass overlying the anterior LV, huge mass overlying the lateral LV, and the apical 3-chamber view on the bottom really tells you what it is, because it's a very well circumscribed mass within the myocardium itself, because you can see the pericardium going all the way around it. So this is just a very rare complication that you see with people who undergo PCI or CAB, or sometimes it'll even occur spontaneously in the setting of a STEMI. This is an intramyocardial, or sometimes also called a subepicardial hematoma. So is there a role for contrast? Well, there must be, because we mentioned that it can be very, very helpful at the very beginning. But this is a good example to delineate why contrast is so important. You can see that this is a cardiomyopathy. The EF, you're guessing it's about 25 to 29%. You can't really see the endocardial border very well. You really can't see the apex. It looks like there may be a thrombus up there. There may be trabeculation. There may be an LV tendon. So this would be a classic case where you'd want to give contrast to make sure that there wasn't a layered mural thrombus up there in the LV apex. And you can see when contrast was given, the walls are all pretty much just hypokinetic, and there is absolutely no evidence of a apical mural thrombus. This is another example of a 62-year-old man with coronary artery disease, and his EF is better. You're guessing that maybe it's in the 40s. You can't really see the apex very well, but if you were reading this, you would not necessarily suspect that there would be anything in the apex. However, when he was given contrast, you can see that he has a focal area of akinesis at the very tip of the apex, and within that focal area of akinesis is a very pedunculated and mobile thrombus. So I'm going to give you some really just quick facts about cardiac tumors, because Dr. Nabi has a much better slide than I do on this one. So we're going to just quickly mention that cardiac tumors are usually metastatic. 95% of all cardiac tumors come from somewhere else. And they're usually coming from other structures within the chest, such as the lung, the breast, but also lymphomas are pretty common. And stomach and liver cancers also can metastasize to the heart. Metastatic tumors almost uniformly involve the pericardium. That's 75% of the time. Primary cardiac tumors are usually benign 75% of the time, and the most common primary cardiac tumor is a myxoma, followed by a rhabdomyoma, a fibroma, a lipoma, a papillary fibroelastoma, and the last two are really quite rare. I can't say that I've seen any of those yet. The most common malignant primary cardiac tumors frequently involve the pericardium also, just like the metastatic ones. So if there's also an associated pericardial effusion, it likely is malignant and not benign. And the most common one is angiosarcoma, followed by rhabdomyosarcoma, fibrosarcoma, and osteosarcoma. So this is a 44-year-old man who came in with shortness of breath. And you can see that there is a huge mass filling up the whole right ventricle in that apical view in the upper left-hand corner. That mass is invading into the right ventricle because you can see the base of the right ventricle is moving normally, but the mid-segment and the apex are no longer moving normally because that tumor is invaded in there. That tumor has also latched itself onto the tricuspid valve and is going into the right atrium, you can see. When you look at on the short axis view in the upper right-hand corner, you can see that there is associated circumferential small pericardial effusion. And the bottom right left-hand corner is to look for perfusion, which can be very helpful in trying to determine what this mass is, because tumors perfuse, thrombus do not. And basically you can see that this tumor is perfusing because there's little white dots within it. That's all where it's taking up the contrast. And the subcostal view again shows you the circumferential pericardial effusion and the invasion of that tumor into the right ventricular mid and apical walls. So this is a 36-year-old woman with dyspnea. This is a TEE. She got referred for resection of this mass. And you can see from this TEE, the reason that they're moving like that is it's showing you the right upper and right lower pulmonary veins. And you can see that this tumor came to the heart through those pulmonary veins. You can see it's completely filling up those pulmonary veins, and that part of the left atrium associated with those pulmonary veins. And when the upper right hand one is showing you the left upper, and you can see that the left upper is free of tumor. So this is a classic example of somebody with a pulmonary sarcoma, which is spread hematogenously through the pulmonary veins into the heart. So with tumors, like we said, they can pretty much do whatever they want. So we do have atypical presentations that we see in the lab all the time with the tumors. So these are two examples. The first one is showing you a myxoma in the right atrium, and the second one is showing you a myxoma in the left ventricle. This happens very rarely. 75% of the time they're in the left atrium. Only 15% of the time are they in the right atrium, and only 5% of the time are they in the LV. They can be in all the chambers, and you can have multiple myxomas if you have some of these familial syndromes, such as NAME or LAM. So this is another atypical presentation of a mass. This was a young woman with Behçet's, and she had shortness of breath. And basically what we saw, you can see in that upper right-hand one that's moving, that there's a mass there, and it looks like it's attached to the chordae of the tricuspid valve. And then in the one below, you can see that it's firmly attached to the chordae of the tricuspid valve. So basically this mass was removed because we had never quite seen anything like this, and we were worried about the embolic potential of this mass because it looked freely mobile in that upper right-hand panel. This turned out to just be inflammation related to her Behçet's disease, and unfortunately it reoccurred post-op. So this is another atypical presentation. This is a 50-year-old woman with hypertension. She just happened to get a transthoracic echo, which you can see in the right-hand panels. And in that transthoracic echo, we saw this very, very mobile mass up there in the apex. So we gave contrast, which is the lower right-hand panel, and you can clearly see that mass. She then had a TEE, not for sure why, because it's very difficult to see apical structures on a TEE, but we were able in that upper left-hand panel to again show that there was a very mobile mass up there in the left ventricle. We could see that the apex was moving normally, so we didn't think this was a thrombus. The thought was that this probably was a tumor, but it seemed to be very mobile, so we were very concerned about its embolic potential. So she actually then proceeded with surgery to have this mass removed. This is actually the video of the surgery that was performed. And in this particular case, you can see that he's just working here to open up the left ventricle. We're going to be inside in just a minute. Here we are. He's just probing the chorda tendinate. He's probing the what's the word? Well, he's probing and looking for this mass, and you're going to see it's right there, and it's very yellow, and it's very mucoid looking, and the question is, okay, what the heck is it? And in the next few minutes, you'll see that he'll get this out because it's very adherent to the, sorry, I'm blanking on the word that I want to use, but it's very adherent to these, to the endocardium here inside the heart muscle here. And this is a very unusual presentation of a papillary fibroelastoma. So papillary fibroblastomas usually form on the valvular endothelium, on the high flow side. So that's how you can distinguish them from vegetations, because vegetations are always on the low flow side. So it's, we used to think it was exclusively valvular endothelium, but as you can see, this formed on the endothelium of the apex and not on the valve at all. And it was a smart move to remove it because they do have the potential to embolize. So what is the role for echocardiography after stroke? Well, echocardiography allows us to identify whether or not there's an intracardiac mass, such as a thrombus, a tumor, a vegetation, that may have partially embolized. So if we see some left, we feel pretty confident saying that was the etiology of the stroke. It also will allow you to identify an abnormality that may predispose the patient to the development of an intracardiac thrombi, such as significant mitral stenosis and left atrial enlargement, or AFib with spontaneous echo contrast consistent with flow stasis within the left atrial appendage, or an LV aneurysm, or an aortic atheroma. And all of these things are considered to put the patient at high risk for emboli. However, it can also allow you to identify a cardiac abnormality that may serve as a potential source for systemic embolism. So these are things that put you at much lower risk for systemic emboli, such as a patent foramen ovale, atrial septal defect, or a particularly large and mobile Lambel's excrescence. A definite cardiac source based on various series is usually found in about 15 to 40% of ischemic strokes. So this is an example of a 64-year-old woman who came in with facial droop. And she was in atrial fibrillation. And you can see this moves really slowly because she's in atrial fibrillation and there's only one beat here. But you can see that there's a freely mobile large mass there in the left atrium, which is threatening to get across the mitral valve on both this apical and the short axis view. So this is a classic example of a thrombus in transit. It's there because of the atrial fibrillation and subtherapeutic anticoagulation. And she actually went to the OR to have this removed and actually had full recovery from her stroke. So this is another patient, and on this TEE, what we saw was this ulcerated atheroma. So this ulcerated atheroma in the ascending aorta, this is considered to put somebody at high risk for future emboli. So this in and of itself is a good find and basically a good lead into what could have possibly been the etiology of that person's cardiac source of embolus. So this is another patient with AFib, and in this one you can see that there's already a thrombus formed along the bottom of that left atrial appendage, and there also is spontaneous echo contrast. So again, this would be a definite visualization of an etiology of this patient's cardiac source of embolus. So here is a contrast injection, and you can see that this is just classic for a patent foramen ovale. We consider this a very low risk for causing embolic stroke. And we see this quite often, and we know that there's approximately 20% of the population who has these things, so we see this on an everyday basis. But I'll tell you, it's low risk, but it's not zero. So this is an example of a patient who presented with a PE, and he had a stroke. And what you can see is there's a thrombus that's literally stuck across that patent foramen ovale. And the right-hand view is just right-hand picture is just a 3D view of it. There are atypical presentations that you have to be aware of. This is a 67-year-old woman who has lupus and a stroke. You can see that she has a very pedunculated mass, which is located on the low flow side of this valve, mitral valve. This is a TEE images. You can also see when we looked in her left atrial appendage, she has a similar but much larger pedunculated mass, which is attached to her intra-atrial septum. And you can also see, looking at her aorta, she has multiple ulcerated plaques in her aorta, and some of those plaques have mobile components related to them. So this is an example of someone with antiphospholipid antibody syndrome, and she had both the lupus anticoagulant and she has significant atheroemboli. So I frequently get asked, what is the appropriate use for echocardiography in somebody with cardiac source of embolus? This is based on the 2016 ASE guidelines for the use of echo in the evaluation of a cardiac source of embolus. And you can see that TEE is appropriate almost 100% of the time. It's appropriate if there are symptoms or conditions suggestive of cardiac etiology, such as chest pain, dyspnea, palpitations, TIA, stroke, or peripheral embolic event. If there's a suspected cardiac mass, if there's a suspected CV source of embolus, as an initial evaluation of infective endocarditis with positive blood cultures or a new murmur, reevaluation of infective endocarditis at high risk for progression or complication or with change in clinical status or cardiac exam, known acute pulmonary embolus to guide therapy, either thrombectomy or thrombolysis, and reevaluation of a known PE after thrombolysis or thrombectomy for assessment of change in RV function and our pulmonary artery pressure. TEE is appropriate as initial or supplemental test for the evaluation of cardiovascular source of embolus with no identified non-cardiac source, as initial or supplemental test to diagnose infective endocarditis with a moderate or high pretest probability, and as the initial test for evaluation to facilitate clinical decision-making with regard to anticoagulation, cardioversion, or radiofrequency ablation. So with that, I'm going to pass the baton over to Dr. Nabi to take you on a whirlwind tour of CMR and cardiac CT.
Thank you, Karla, very much. I have been tasked with the use of advanced imaging for the assessment of cardiac masses, and I will be discussing a lot of the same things Karla did and show you how we can use CT and MRI and a little bit of PET in the evaluation of our patients. So we're in the echo lab and you see a mass, and as Karla had said, usually the differential is one of four things. Either this is an artifact, a / normal variant, this is a thrombus, this is a vegetation, or is it a tumor? And we know for sure echo is the first line test for all the reasons Karla has gone over, but there are certain disadvantages that I would like to highlight. And that includes oftentimes we are limited by the acoustic windows we have, and therefore we may not get optimal imaging of the structure of interest and especially on the right side of the heart. And there are patient conditions such as COPD or obesity that can limit the quality of your images. And I think the most important disadvantage, though, is the inability to perform tissue characterization, where these advanced imaging techniques can really make a difference. So I'll be talking mostly today about cardiac MRI and cardiac CT. These are two techniques I think the public now is very familiar with. These are techniques that have, as you know, a very large field of view. You're able to make multiplanar reconstruction of all your images. And this is really helpful because not only do you see cardiac anatomy very well, but as Karla had elucidated as well, that you're able to really look at extracardiac manifestations. These techniques have tremendous spatial resolution, very good temporal resolution, and these techniques allow us the opportunity to perform tissue characterization. All of this becomes very important when it comes to describing your abnormality, really localizing it, and then developing a differential diagnosis for what the suspected mass could be. Now, how do CT and MRI provide incremental value to echo so they can really contribute to a differential mass, differential diagnosis? They can really help you define cardiac and extracardiac structures, really help you to stage and plan therapy, and really, once the patient has had some definitive treatment, for ongoing serial monitoring. Both these techniques, you should know by the 2019 appropriate use criteria, are indicated techniques. So let's begin with cardiac CT. In general, when we perform cardiac CT for a cardiac mass case, there's a particular protocol we follow. We begin with a pre-contrast study, so we don't deliver any contrast, and we take an image of the chest. And really the importance of this group of images is to identify calcium or any surgical material that has a hyper attenuation that we would be able to see. The second part, obviously, is when you give the contrast. Now is really the opportunity to visualize all the vascular structures in the heart, to be actually able to see the mass, and then, of course, you can also look at vascularity. And then finally, we follow this up usually about 30 to 40 seconds later with a post-contrast image, so that we've kind of allowed the contrast to equilibrate, and we're taking an image at least 30 to 40 seconds later. And here the idea is to, similar to cardiac MRI, to determine whether there has been any iodine uptake in the mass. How does CT help us? Well, there's many different ways. As you well know, this is again a very large field of view technique. So we're seeing the entire chest, we're seeing the lungs, we're seeing the vasculature. All of these can be independently analyzed. We know some masses can involve the coronary anatomy, or we're maybe interested as to how a lesion may be getting its blood supply. So knowing the coronary anatomy can be very important. Equally, if this patient is going to be going on for surgery, knowing coronary artery anatomy also becomes very important. And then finally, cardiac CT can be very helpful with staging. And this image that I've shown, you can see a large multiple metastasis to the liver, which would definitely change the prognosis and treatment of your patient. We can perform some basic tissue characterization with CT. This is a nice table which goes over different Hounsfield units or characteristic CT attenuation properties of different tissue structures. Air is usually -1000, fat is usually -100s, water is 0. Tissue will be between 50 to 80, contrast 300, and bone and calcium greater than 1000. So here in this particular mass, you can easily just draw a region of interest, and you can see here that the average Hounsfield unit in that region of interest is about 78 Hounsfield units. And this gives you an idea as to what's the basic composition of the mass that you are seeing. Now, what are some masses that CT is really good for? CT is great for calcium. And in fact, here's a patient. We've seen a lot of cases of MAC. Here's another one by echo. You don't need all these imaging techniques, but if there was some concern, simply a non-contrast CT scan, as I'm showing you on the right group of images, can demonstrate calcium definitively without doubt. Another mass that CT can be very helpful with is fat. Fat, again, has a very typical Hounsfield unit, again, in the -100s. This was a large lipoma of the heart, 2 different types of lipoma. You can see they give a very dark image on the CT's images, and when you draw your region of interest, you're going to find Hounsfield units less than 50. It's interestingly, our neurologists here are now increasingly ordering CT as an evaluation of patients with stroke, and our electrophysiologists are also obtaining CT now to rule out left atrial appendage, left atrial thrombus. And I thought I would just share with you how we actually do this. So here are 3 different patients, and the information that we have is an arterial phase followed by the delayed scan that I had told you about, which is done usually about 30 to 40 seconds later. And what you'll notice in the first case is you have no filling defect on the arterial phase, and it's of course completely normal on the delayed phase. On the second group of column of images, you can see there's a filling defect on the arterial phase, which persists on the delayed phase. This is very consistent with thrombus. As you know, thrombus is a structure that is avascular and does not take up contrast. Contrast this to the final group of images, where you see a filling defect on the arterial phase, which completely fills in over time on the delayed scan. And this is similar to what we see often when we're performing TEEs, which we consider slow flow. If you'll see a lot of smoke in the left atrial appendage. It looks like a filling defect, but as you're watching it, it kind of washes away. So this is considered, stasis or slow flow. I think talks would be incomplete now if I didn't mention PET. Of course, PET can be a very, very helpful technique. Oftentimes, tumors will take up FDG, and it can be very helpful in differentiating benign and malignant tumors based on the SUV that you're able to measure. It can definitely help with staging of malignancies, optimizing biopsy location, and planning radiotherapy. Now, advantage of CTs, I think we've gone over. It's really a fast technique, you get coronary information, and it can be very helpful with calcified and fatty lesions. But there are disadvantages that we have to keep in mind. There is a radiation dose that is delivered, and especially if you want a technique that has high temporal resolution, then we're gating the entire cardiac cycle, and that can be quite a radiation dose. We may want to be cognizant, especially in young patients or female patients, especially those who may be going for serial imaging. Of course, there's a small risk of contrast-induced nephropathy. It does have limited temporal resolution if you're just taking a quick snapshot of the heart. And when it comes to a comparison to MRI, it definitely has a limited soft tissue contrast. So this is really where CMR can have many advantages. As you know, this is a technique that has a lot of strengths of CMR, of CT with a high spatial resolution, and has additional strengths which include the high temporal resolution, and then many different sequences which actually allow you to probe the actual tissue characterization of the structure that you're interested in. So it actually allows you to almost be a pathologist without having to cut a patient and to obtain actual tissue. So how do we go about doing this? There's 2 broad groups of images. One is a functional images that we get, which y'all are all used to seeing. These are your basic cine images of the heart. Note that we can make any plane that we want of these masses. We're not really limited by any particular view. And then the next series of images are structural imaging, where we really assess, what the characteristics or the makeup of the mass is. And there's a group of sequences that we do that are done before contrast, and then there's a group of sequences that are done after the administration of contrast. And I will go over that. So if we go back to our functional imaging, this is just an example of that. We have a whole stack of imaging going through the chest. We can really create very high temporal resolution cine images of this mass here that you're seeing in the right atrium. And like all the techniques we've been talking about, can be very helpful for sizing, locating, assessing invasion, and looking at extracardiac structures. Where I do want to spend some time, of course, is in the ability to discriminate tissue characteristics. And again, this is done by 2 different ways. One is a group of sequences that we do before contrast. And these are really your T1, T2, and T2 star sequences. T1 is a sequence that can help you look for fat. Our T2 weighted images help you look for edema, water. And then finally, our T2 star sequences, which help us to identify iron or blood breakdown products. We then deliver the contrast, and contrast, we can actually watch the flow of contrast go through the cardiac mass, and this can be very helpful for us in determining how vascular a structure may be. We then can perform your typical delayed hyperenhancement, and any evidence of contrast uptake by the mass would be indicative of fibrosis, necrosis, or inflammation. And then finally, we have a sequence post-contrast known as our long TI imaging. And this is really a sequence that I want you to be familiar with, because this is our thrombus probe. So when we're specifically hunting for thrombus, we go to this particular sequence, and I will try to explain why in the upcoming slides. So I think, when Karla and I and the rest of you are evaluating cardiac masses by any technique, the first things we try to do are figure out, is this a true mass or is this a pseudo mass? And Karla showed you many pseudomasses, and I will do my fair share as well. Here was a mass seen in the posterior right atrium, referred for cardiac MRI. And here I think, very clearly now you can appreciate that this was not an abnormal mass, rather this was simply a prominent crista terminalis. Similarly, if I were to show you this group of images, okay, you would see a structure that would move in and out of the left atrium. And if you looked at this patient, had abdominal pain but was referred for a cardiac MRI, you can see actually was nothing in the left atrium. But if you looked at the survey through the chest, you saw a very large hiatal hernia, and this was likely the cause of the artifact we were seeing on the echo images. So I will only highlight what Karla said, was that it's really, really important to know your cardiac anatomy. You really have to know what normal structures, and there's many tables out there that can, by each specific location in the heart, can tell you, what are the most common true tumors that should be there, as well as pseudo tumors that are normal structures but can be often mistaken for tumor. Once we have identified pseudomass versus true mass, and we've made the decision that we have a true mass, then really it becomes a conversation as, is this really a tumor, or something that would need to be excised, or is this something, is this a pseudotumor that may not necessarily need a surgical treatment for? And these are things like fat, fluid, calcium, thrombus. The overriding principle that I would like you to get out of determining what we use with advanced imaging when determining whether something is a pseudotumor is, these four things in general will not take up contrast in any of our contrast images. So let's show you some examples. Here was that large dumbbell-shaped mass in the intraatrial septum sparing the fossa ovalis. This patient can be although we know what it is by our echo images, but if you really wanted to probe its actual tissue properties, this demonstrate brightness on T1, darkness on T2 with fat saturation. There is nothing that does this combination of appearance on on these CMR sequences other than fat. You can be 100% confident that this is lipomatous hypertrophy of the intraatrial septum. Similarly, you have this large mass in figure A abutting the right side of the heart. You may not exactly know what it is, but just by probing its tissue characteristics, here the opposite of what we saw on the last screen, dark on your T1 images, bright on your T2 images with no evidence of LGE. There's nothing that does this other than water. This is a pericardial cyst. Here was another mass. This was an interesting case. This patient was actually referred, had recent double vessel bypass, but on postoperative imaging, there was felt to be a mass seen in the left atrium and was referred for further evaluation. Now again, when we actually look at the different sequences that we use, both pre and post contrast, to assess its intrinsic tissue characteristics, I have those shown for you. What you'll notice in all of the images that I show, it is dark. And the only thing that does this, that has a dark appearance on every sequence in MRI, is of course calcium. This was a case of caseating mitoannular calcification. As you know, calcium is not made up of protons and therefore would not be expected to give a signal in the MRI environment. How about this case? This was a diabetic MVR in 2009 with chronic atrial fibrillation on anticoagulation who's admitted for heart failure. Echo showed masses in the right atrium, and here you go. CMR shows two large masses, almost trying to prolapse across the tricuspid valve in diastole. If we look at our tissue characteristics again, pre-contrast images really show no difference compared to the myocardium. If we look at perfusion, you're actually watching the flow of contrast through the right side and therefore interacting with these large masses in the right atrium. You can see the masses take up no contrast, so they appear to have very poor blood supply. But in this particular case, we have a very particular sequence. This is our sequence called the long TI imaging sequence that I had mentioned. This is what we call our thrombus probe. This, in the MRI environment, we create a very long inversion time. This allows most structures that would take up contrast to take up contrast and appear bright, whereas only structures that are completely avascular, hence by definition a thrombus, would appear dark. And what you're seeing here is definitive, evidence by assessing, the intrinsic tissue characteristics of this mass, that this is nothing but two large thrombi in the right atrium. And this was confirmed by surgery. Here's just an example from the literature on the cine CMR images. You can see a protruding pedunculated mass across the mid-anteroseptum. But when you perform this long TI imaging, notice how clear the difference in soft tissue contrast between the normal myocardium and the thrombus is. The myocardium now starts taking up contrast, is brighter, the thrombus stays completely dark, really helps you visualize it, where it can easily be even missed on your cine CMR sequences if you're not careful. And this patient was treated with anticoagulation, and you can see here with complete resolution of the thrombus. This is just a slide showing, one of many that, when it comes to the different CMR sequences, really long TI imaging has the highest accuracy for thrombus. If you look at data in the literature, these were patients who had transthoracic echo, TEE, cardiac MRI, and then went on to have LV reconstruction surgery, so therefore pathological confirmation of the presence or absence of thrombus. And you can see here MRI had the highest sensitivity and highest specificity for the identification of thrombus. If you look at using CMR as the gold standard for the definition of a thrombus, and then compare a non-contrast echo, contrast echo, and cine CMR, you can see here that if you're not using contrast, you're going to be missing a lot of thrombus. Once you give contrast, definitely you're going to pick up a lot more. And even cine CMR is not perfect when you compare it to long TI imaging. And what were the thrombi by echo that were most likely missed? It was cases just like in this picture that I have for you on this slide. Those thrombi that tend to be small in shape or laminated or mural in nature, these were the ones that were most easily missed because they kind of just blended in with the wall. Whereas with our long TI imaging, you really get that great tissue contrast between an avascular structure and vascular structures. And a final slide just showing you that, of course, cardiac MRI can be very helpful in really identifying substrate in the myocardium that can predispose you to thrombus, which includes, depressed ejection fractions, wall motion abnormalities, and of course, severity of scar. So once you have ruled out the pseudotumors, those are the ones that don't take contrast and may not necessarily need to be surgically excised, well, then everything else starts taking up contrast, and this by definition is a tumor. And I will pause there. Notice I'm not saying benign or malignant, I'm just saying it is a tumor. And studies have shown this. This was a large group of patients where they looked at the difference in between thrombus and tumors. And what they showed you was tumors do, in comparison to thrombus, number one, are bright on T2 imaging. And number two, in every sequence that where contrast is administered, they take up contrast. So they'll take up contrast in first pass perfusion in your LGE images, whereas, of course, thrombus does not. And when it comes to, if we go back, the next step, obviously, once we have a tumor, is then developing a differential diagnosis, whether something is benign or malignant, and how we can use our advanced imaging to help us with that. So in order for us to do that, it's important to go also mention what Karla had mentioned. You have to a little bit know about the basic prevalence of cardiac tumors. Most common are the secondary cardiac tumors, which are the metastases, and we went over that. Most primary cardiac tumors tend to be very, very rare. Most common primary cardiac tumors are fortunately benign, and those are your myxomas. And if they are malignant, then they become your angiosarcomas. But how then do we, once you identify a mass that takes up contrast, how do we start figuring out whether something is benign or malignant? What is this actual object we're seeing? And here, in all honesty, it's more than just tissue characteristics. You really need to take 4 things into account. You have to know the patient's age. Clinical history becomes very, very important. Tumor location becomes very important. Here was a slide on the right. You can see where although there's an exception to every rule, and Karla shows you some very nice exceptions, but most common locations of different types of benign and malignant cardiac tumors in the myocardium. So it's good to have knowledge where most commonly these structures tend to want to go to. And then finally, of course, tissue characteristics, of course, can also then help you create a differential diagnosis. And there are many tables out there in the literature, and if we were to, as a reader, I'm not trying to memorize these tables in order to come up with a diagnosis, but I'll give you some tips and tricks that will make your life a lot easier. So when it comes to malignant versus benign, remember, malignant lesions look really bad. They tend to be much larger in size. They involve the right side of the heart. They're may be multiple. They'll have irregular borders. They're going to be invading structures, and you're going to see pleural and pericardial effusions, just like Karla mentioned. Benign tumors will tend to be smaller. They usually involve the left side of the heart, and they're going to have your smooth margins and stalks and things like that. So just the visual characteristics of it become very, very important. If you get into what studies have shown that malignant tumors demonstrate a lot of LGE uptake. So if you have a mass that takes up a lot of LGE, more than likely it's going to be something malignant. Dr. Shah also has published on this. He came up with 3 variables. If you know 3 variables, you can very easily help you with good diagnostic accuracy figure out benign and malignant. If you can figure out whether the lesion is invasive, if you can figure out how much vascularity there is, and the size of the object, as you can see in this flow diagram in their paper, you can have almost a 92% diagnostic accuracy for malignancy and a diagnostic accuracy of 100% for benign, knowing those 3 characteristics. So, and this is just a paper from the literature as well, showing you two masses, one benign, one malignant, going over what we talked about. The benign lesion tends to be small in size, smooth borders. The malignant lesion is very large, it's invading borders, there's an effusion, it's irregular. All of them will show evidence of brightness on T2. Both will show contrast uptake. The sarcoma will have a lot more contrast uptake than the myxoma and have a lot more vascularity as well. And then these were shown histologically as well. So I think I'll start concluding by going over that, when you have a mass, we have a lot of advanced imaging techniques that can help you to really pinpoint those cases that may not need surgery and those cases that where you have a true tumor, and then further help you to be able to figure out benign and malignant or create a very solid differential diagnosis. You should know about what techniques are available in your institution and your patient and test characteristics, so you can choose properly between CT and CMR. Here, and TEE, here is some suggestions that we propose. And I will summarize by just saying that both CT and CMR can really, with high specificity, identify masses that do not need excision, your pseudomasses, your thrombus, your lipomas, your water-based cysts. You can definitely create a solid differential diagnosis, knowing 4 things: age, history, location, and imaging findings. But at the end of the day, tissue for tumors becomes very important. Thank you very much.
Thank you, Dr. Nabi. While you were talking, we have so many questions. So we're going to try answering some of these questions. The very first one was talking about a paraganglioma and what the best imaging technique is for that. Of course, these paragangliomas frequently involve the mediastinum, they frequently involve the pericardium, sometimes they can also involve the atrium. Echo is not going to be the best way to visualize those tumors. So I'm going to pass it over to Dr. Nabi because it really is going to be CT, CMR, or PET.
Yeah, absolutely. For paragangliomas, the advantage here is MRI, and the reason is because, number one, they tend to be, like Karla said, in the, at the base of the great vessels in the mediastinum, so you really need a technique that can be able to see that. But also, more importantly, these are highly vascular structures. And so, as we had discussed, one of our protocols that we use is this dynamic first pass perfusion, where we actually assess the perfusion. And so if we see a structure, involving the base of the great arteries, very, very highly vascular, paraganglioma is a strong consideration.
So there's a whole bunch of questions about how, where thrombi are in the left ventricle, whether or not they're always in the apex, whether or not you always have to have regional wall motion abnormalities associated with them. So I'll start and I'll let you finish. So of course they're not always just in the apex. It's just that's where the aneurysms are frequently seen in most patients because of that, the LAD disease, that when it's occluded frequently you develop an aneurysm there in the apex. However, I have seen thrombi in inferior, posterior, basal aneurysms also. I've seen aneurysms there, and I've seen thrombus inside of those aneurysms. So basically, you just need an aneurysm, which sets you up for a very low flow area. If you have a very low flow area, this predisposes you to stasis. And if you have blood stasis, then the clotting factors just have enough time to form a thrombus there. Of course, other low flow states, you don't always need segmental wall motion abnormalities to have a thrombus in the left ventricle. You just need a low flow state. So if you have somebody who has an EF that's really, really low, like less than, and the same for mitral stenosis, because there's a stenosis there in the left atrium so big and it's a low flow state and there's a lot of stasis there, that left atrial thrombus doesn't have to be always in the left atrial appendage. It can be in the left atrium itself. Just because of that low flow area. So I'm going to pass it over to Dr. Nabi and see what your comments are on that.
At least when it comes, my only point on thrombus is, more than likely you're going to see wall motion abnormalities and things like that. There's always an exception. I understand that. That's really where the strength of CMR and CT can really play in. These techniques really do not necessarily need the wall motion to be able to determine whether something is thrombus or not. They can probe the intrinsic tissue characteristics of the mass, and here of thrombus would be specifically they are avascular structures, and both techniques can very solidly evaluate and rule in a thrombus based on those properties.
So there's something about imaging tips to tell if a shunt is due to the invasion by a tumor or due to a congenital defect. So if we're talking about congenital heart disease, MRI is always queen here, or king, both. So I'm going to pass this one over to you, Dr. Nabi, and see if, because I think it's pretty easy by MRI to tell if there's like a fistula there from invasion from a tumor versus like some sort of congenital shunt or ASD or VSD.
Yeah, I'm trying to understand this question. I mean, I think there's 2 points. Maybe they're trying. I'm understanding. You know, if there is a congenital defect, obviously techniques like CT and CMR are are really very helpful when it comes to congenital heart disease. With CMR, of course, you can quantitate flows and you can really assess QPQS and determine how hemodynamically significant shunts are. If it comes to a tumor that is destroying, tissue structures, and you've actually created fistulas and holes in the heart, but in both of these techniques, because of their spatial resolution, should be able to allow you to see that very clearly.
So the second question, the absence of wall motion in the particular region containing the mass, a good argument against LV thrombus. So in the case that I showed you, yes, because in that particular case, it was a structurally normal heart. So the EF was normal, wall motion was normal, everything was absolutely normal. So in that particular case, when you have normal and you don't have a low flow state at all that would predispose you to stasis, that's pretty much enough for me to say that, no, this isn't going to be a thrombus, this is going to be a tumor. What do you think?
Yeah, absolutely, Karla, and I'll only add for us, it becomes we're really probing the tissue properties. So if I see something is avascular, it doesn't take up contrast by CT in our delayed imaging or by CMR with a long TI imaging, I'm very confident it's thrombus.
So I think we've answered this question pretty well. Aside from clear aneurysms or segmental wall motion abnormalities, how far can imaging help to assess patterns of intra-chamber flows that predispose to LV thrombus? We talked about low flow states and aid the differential diagnosis. Because I'm speaking on behalf of Echo, Dr. Nabi is clearly saying that he can do tissue characteristics on that mass. If there's any question at all, if the Echo isn't helping you to determine whether or not there's regional wall motion abnormalities or whether or not it's a low flow state because the images are technically difficult, well, of course, the next step would be to get an MRI to do tissue characterization and answer that question with 100% certainty. Wouldn't you agree?
I agree, Karla. And I think one of the questions I saw was flow patterns. I think maybe they're referring to CMR 4D flow. This is a research tool, a lot to be investigated. That's data to come out whether we could predict who will go on to develop a thrombus.
When a mass is localized on a septum, are there tips not to miss an underlying surrounding small defect? So for echocardiography, the tips are multiple different views. You also want to give saline contrast if you're looking at the septum to see if you can get contrast to go across that mass. For example, in that ventricular septal defect case, you might not be able to do that, but if it was an atrial septal defect, you clearly should be able to get contrast to go across there, even if there's an attached mass of some sort. I think, though, again, echocardiography probably won't give you all the answers that you want, and I think that you would probably want advanced imaging with MRI. What do you think, Dr. Nabi?
I agree, Karla.
Okay, and our very last question was about the parameters to diagnose a cardiac paraganglioma. We already discussed that. Thank you all very, very much for all these really good questions. And again, tune in next week. There'll be another fascinating and very entertaining MMI conference. Thank you.
Bye, everyone.